Hello, welcome to Philosophy Roulette number 183, where I read and review philosophy live on air. It's my first time reading it, and so if you have any suggestions or things I should read, because I ain't read most things, feel free to send it along. But let's just see what's on the front page. I realized last time I've got a little problem with my search feature, but but that's okay. I forgot about the dog bark too on that. But let's see what we've got. Acta Biotheoretica. A lot of times I want to read philosophy biology. It's such a cool topic, but it's a lot. I can't really read sciencey things on this because it's just very hard to read off like scientific information. But I'll take a look. Review, corrections, and synapomorphies behind shared derived characters. Examples from the great apes and genomic data. See, that's the thing. If I have to read off like descriptions of genomic data, can't do it. Retraction note. Ooh, interesting. Haven't seen retraction notes in philosophy too often. See, latitudinal gradient and species richness. Interesting. It's 3 pages, but see, it's let's see, the latitudinal gradient. Well, let's just even see if it's available. If it's not available, there's no point. Cultural evolution of human nature. Okay, that could be cool. Let's take a quick look. I'm afraid that's going to be very long, actually. GPU algorithm. I can't read that. Sensitivity analysis. For left ventricle model. Alright, let's just see what we got. Mid effects latitudinal. Alright, not here. Let's see if it's available. Usually. Ooh, let's just take a look quick to see if this is readable. But if it's all sciencey stuff, I can't really do that. Yeah, see models and stuff. Okay, this is way too short, and it's talking about models. See, that's the problem with that. The cultural evolution of human nature. Let's see. HTML. Oh, it's a free to read one. Let's take a look. Oh, it's a review. Okay. That's why. So it's a essay review of something else. Alright, but since I haven't read that, it makes it very hard. Alright, that's why I don't do these things. AI in Society, I've read some stuff from them before. Depends on what they got. Let's take a quick gander over there. I'd love to do some logic, but again, actually I'm not that good at logic. I can't really do much of it, but I like looking at it. I wish I could read this foreign language. I'm sure the Poles have, like, I think it's Polish. The Poles are, like, famous for their logic. It's great. Yeah, welcome. If you have any questions, please feel free to ask. I just sort of read philosophy and review it here. So what is this, a Spanish journal? Unfortunately, I speak English and bad English, so I can't do Spanish. Let's see what we got. Oh, let's go to page 2 then. Wow, Argos, it was all Argos. They sort of have taken over the first 2 pages. Asian Bioethics Review, again, with the biology. Alright, maybe if it's bioethics, I can take a look. Let's see. Augustinian Studies. Ooh, more Ooh, so much bioethics. Let's keep going. Alright, so let's see what AI in Society has. These folks have their double paned floss journal, so they're basically twice as much. It has to have the should just go for the half size ones. Let's see, double question marks. Why friendly AIs won't be that friendly? Oh, I read this stuff right. Okay, so I don't have anything new here. Let's see if the forthcoming is a bit better. Let's see what we got. Hard problem of AI rights. 1 to 14, that's a little scary. 1 to 2. Mental 1 to 20. Yeah. The rise of our... Okay, and that's it. Read all of those. Okay, so let's move on. Rationing in a Pandemic, Lessons from Italy. So that could be an interesting paper. Let's see if that's available. This looks like a review. It's very short. Age matters, but not means to discriminate. Let's see what else we got. Vietnam's response. enacting bioethics locally review, exclusion of migrant workers from national UH system, perspective of healthcare and nonprofit. In Singapore, sharing information on COVID-19. Let's see what else we got. Super spreaders, definitional quandaries and implications. That could be interesting because it's not just going to be science stuff, at least. Definitional. Ethics of the reuse of disposable medical supplies. Yep, let's take a quick look at that because that's getting into philosophy of technology actually, like what counts as a resource, and so that might actually be touch on some interesting metaphysics. Ethical practices and legal challenge mental health research. All right, let's see what else we got. Yeah, I kind of want to do that one on the see if that one on. Yeah, see, rationing is the same thing. This is all resource stuff. And so this is kind of an interesting topic. How do we understand resources? Oh no, it's not available. Dagnabbit. This one could have been like super interesting. Single-use items. This has like implications all over the place. There'd be a lot of. I'm sure this is an interesting paper. It's too bad. Goodbye. Let's go look at the rationing one then. See if this one's available. Yes, looks like it's alright. This one looks okay. Let's go for this one, see how long it is really. 1 to 6. Okay, that's what we're gonna do. Because that seems cool. Oh, it's a perspective, that's fine. So you got these different sorts of articles. This one says perspective on it. We're gonna load? We did load. Nice. Okay. So, what do we got here? Let's just get everything set up a little bit. If you want to grab the link, it's now in the chat. It will be in a sec. There's the link to this page, and if you join later, always you can always type !paper into the chat, and it will pop back up. So, sorry about that. I've got a pop filter now. You can see it. I like my pop filter. See-through pop filter. See this? Pop filter. Okay. Rationing in a pandemic. Lessons from Italy. Here we go. In late February and early March 2020, while infection rates in China fell, Italy became the European epicenter of the coronavirus SARS-CoV-2 2020 epidemic. At the beginning of May 2020, Italy entered the so-called Phase 2, consisting in a progressive reopening of business and social activities while monitoring the eventual raise of the epidemic curve. Rise or raise? I don't know. Phase 2 posed a number of ethical questions, such as finding a new balance between personal liberties and public health, privacy concerns from the use of movement tracking apps, and down the line access to vaccines or improved medications. We think that it is, however, important to look back and determine which lessons can be derived from the way Italy confronted the scarcity of medical resources available to confront the epidemic, especially since this experience can prove invaluable for other countries that are still facing the epidemic peak. In this paper, we analyze the features of the Italian recommendations, why the raised heated debate, and why it is important to have ethical guidelines and balanced and consistent allocations procedures to prioritize patients. One interesting thing that actually just happened here in the United States, and feel free to ask questions anyone out there watching, is that we have a issue with they've made it illegal to repair your own devices here. And that, because like, you know, the manufacturers want you to have to go back to them to like get repairs done so that they can sort of control the whole ecosystem around their devices and make a lot more money, because if they control the whole ecosystem, then they control all the apps, the repairs, all the accessories, all that stuff. So, but when it comes to medical devices, you can't send everything in. You can't wait 3 weeks for like the big medical device company to repair it, especially if you have like someone on hand that can do it themselves. But if it's illegal to do that and that like voids the warranty, that keeps people from fixing devices that need to be working. And so we have a whole thing here where we can't fix our own devices even if they're easily fixable. So this is one of these things that's like just popped up in the last few days, that they're introducing legislation to force the companies not to void the warranty or whatever when you fix the device, or not make it illegal for someone to fix something if they're not like certified by the company. Okay, continuing. There's a very pressing issue right now. The recommendations issued by the Italian Society of Anesthesia, Analgesia, Resuscitation, and Intensive Care. I wonder what the acronym for that is. It's kind of cool. In March and April of 2020, a huge effort was made by the national government to flatten the epidemic surge by enforcing increasingly stringent containment measures in order to reduce the impact of the outbreak on the health system. Despite facing a likely major social and economic crisis, the Italian government imposed a nationwide lockdown on 9 March. Prohibition of all movements of people within the whole territory, and closure of all non-essential business activities. Some think a systematic and strong response arrived too late. Such measures inevitably have a delayed impact, and hospitals were hit by what has been called a medical tsunami, with a high caseload punctuated by a stream of deaths. The enormous challenge for the health system, facing dramatic shortage of ICU bed and staff, has been how to meet the medical needs of patients affected by COVID-19. Even though authorities state that no cases of people who failed to get into intensive care have been reported, many Italian physicians working in ICUs in northern Italy have stated otherwise, as has the mayor of Bergamo, one of the hardest hit cities. No cases of people who failed to get into intensive care have been reported. Yeah, that's like the United States level of just ignoring facts. I mean, people can't get out of their homes. It's like sometimes if they can't make it to them, and they're saying, "Oh yeah, you can't get into them." People are getting, I don't know if they're getting denied, but they're getting pushed around in certain cities here where you can't go to one hospital, so you have to go to another one. And I'm sure, like, okay, so no one failed to get into intensive care. Yeah, but how long did it take for them to get into intensive care? It may have been too late at that point. So we'll see. Professionals experienced uncertainty and distress about how to allocate the dramatically scarce resources available, as that situation was unprecedented for everyone. In some hospitals at the peak of the surge, the rationing involved not only ventilators, but oxygen as well. Yeah, here we don't have PPE. We can't even get, like, people had plastic bags on them to protect themselves. At the beginning of March, some hospitals around Milan were already collapsing. Some of them admitted more than 200 patients with severe respiratory failure every day. As difficult allocation choices were already being made, clinicians, including one of the authors, MV, of the ethics section of the Italian Society of Anesthesia, Analgesia, Resuscitation, and Intensive Care, yeah, this is what I want to see. Look at that. This is a cool acronym. Were asked to publish guidance on the allocation of limited resources. They worked between shifts to construct recommendations that sparked a heated debate immediately after release. I'm completely not surprised that this caused all sorts of debate. Okay, box 1, key elements of CRT recommendations. Let's read this. 1. When the availability of resources is overwhelmed by their need, a decision to deny access to one or more life-sustaining therapies solely based on the principle of distributive justice may ultimately be justified. Criteria for allocation should be flexible and adapted locally in response to available resources, the potential for a patient transfer, and the ongoing or foreseen number of admissions. 3. An age limit for admission to the ICU may ultimately need to be set. 4. Together with age, the comorbidities and functional status of any critically ill patient should be carefully evaluated. 5. Every admission to the ICU should be considered and communicated as an ICU trial. The appropriateness of life-sustaining treatments should be reevaluated daily. Okay, so this is distributive justice is what we're going for here. All right, so this is an interesting concept in itself. I'm sure they're going to discuss it more. And so it's like, this is clearly not what you want, because if you have to ultimately justify distributive justice, it implies that this is a less than ideal sort of justice. Let's see, flexible, and sort of you have to make the people on the ground have to make the decisions, and then okay, so we got the kind of justice we're talking about here in 1, and then who makes the decision is the local folks, and then all of a sudden we've got the criteria in 3, 4, and 5 of sort of like how to scale who gets what. So that's very this is interesting. So we've got the first two are sort of like how this is going to happen, and then this is like how they decide what is going to happen. Okay, so I got sort of a 2-part 5-point criteria, really. The recommendations issued by CRT suggest that if a choice to rational medical equipment and intervention is needed, the maximum individual benefit in terms of expected life years, likelihood of survival plus remaining likely years of patient's life should be prioritized. That's the distributive justice. Who's going to have the best life for the longest amount of time? According to this principle, the recommendations suggested evaluating age, comorbidities, and functional status of any critically ill patient. This was subsequently criticized as ageist, as well as unconstitutional and discriminatory against elderly patients. It was perceived as not consistent with the values on which the healthcare system is grounded. Yeah, but that doesn't necessarily mean that's the wrong thing to do, just because it's not the healthcare system. The healthcare system is not set up for trauma like this. So that's interesting. Should we be defaulting to what the healthcare system is doing when the healthcare system has failed? I don't know. I mean, it's in fail state, so why should we be defaulting to the failed state principles? Well, to be fair, I'm sure the principles had very little to do with the fail state. But anyway. According to the CRT guidance, the drivers of decisions for admission to ICU should be the clinical picture taking into account biological, not merely chronological age, comorbidities, and pre-existing functional status. This kind of soft utilitarian approaches are already applied in Italy in specific fields of dramatically scarce resources, such as organ transplants. This approach is justified by the need to maximize the achievable benefit in terms of life years gained, thus optimizing the use of available resources. Not only the probability of survival and the greatest life expectancy are considered, but also the predicted length of the ICU stay and hence the use of intensive care resources. Nonetheless, this kind of approach is the opposite of the egalitarianism that pervades the wider Italian healthcare system. Okay, so they're saying usually you're egalitarian, but then when you're in the critical things, they stop being egalitarian. Then they start looking into other factors, which is kind of, I mean, we do that here too. I think once you hit 70, it's a lot harder to get organ transplants in the United States. I'm not entirely certain about that, but I'm pretty sure that like there's a age cutoff where you're prioritized if you are like 69 years of age, but once you hit 70, then like if someone was 69, they would be bumped ahead of you. You have to, like, that's where they put the cutoff. One of my parents' friends needs a kidney, I believe, and she was saying this the other day, and it's kind of hard because it's like 70 now, you could live another 20 years, but I mean, it's hard enough to get a transplant match. Sometimes in pursuing what is good, we run the risk of forgetting what is fair. In emergencies, the patient-centered duty to care needs to be balanced with the public-focused duties to promote equality of persons and equity in distribution of risks and benefits. Also, individual allocating decisions must be supported by fair institutional processes that may include strategies such as preparing, conserving, substituting, adapting, reusing, and reallocating resources. Okay, so this is sort of poking holes in the idea of egalitarian. Like, you're already doing a lot of this stuff in the background. Like, this right here is saying, look, it is normal practice for us to be doing all these sorts of, like, accommodating different sort of understandings of what's going on, even behind the scenes when we're doing the egalitarian thing. So just because we're saying it's egalitarian, it's still operating in this sort of consequentialist manner quite often. So it's not so egalitarian, it's egalitarian by means of this sort of consequentialist forecasting of what's going to be needed. So, okay. Continuing. In every single country facing COVID-19 emergency, if no ethical guidelines or balanced and consistent allocation procedures are applied to prioritize patients, there is a concrete risk for unfair choices. Should the shortage arise with no rationing plan in action, hey, welcome to the United States. Decisions would be left to the ruling of local healthcare and hospital authorities or to the clinician's judgment in the heat of the moment, resulting in approaches both inconsistent and uncoordinated. One motivating concern for the CRD guidance was the real chance that the prevalent criterion would be first come, first served. Such an approach appears to remove responsibility for choice over life and death and can be thought as avoiding having to make ethically fraught choices between patients. We will only point out in passing that from an ethical standpoint, there is no actual difference between action and inaction when they both cause harm and injustice. Choosing first come, first served is to be responsible for the foreseeable, avoidable deaths of many in a pandemic. What's up, Arcel? Yeah, it's a little late here, but I was just like, you know what? Let me go serve the Asian market for once. I hope you're having a great night. Thanks for stopping by. Moreover, this approach would also carry the huge risk of social unrest and riot due to the Russia. To the rush of obtained hospital beds, or at the very least hospital overcrowding, with the ensuing risk of further spread of infection. Yeah, are you still playing the Drop Man? What's it called? Oh, shoot. Forgot the name already. Those guys are funny. It's a fun game. Okay, yeah. I agree with... Yeah, Fall Guys, exactly. It seems to be, like, all the rage. Yeah. I would actually appreciate, like, a little philosophical analysis on that game. I mean, it's basically like Maze Runner, one of those, like, everyone dies except for, like, one person, and you could do, a whole, like, ethical analysis on that game. The collective action and all that stuff. Yeah. It'd be funny. Like, you do it for 5 minutes. Exactly. A metaphor for life. And you could, like, it'd be, something... I would be entertained. I don't know about anyone else. Well, that's the whole point. It's like baseball. Everyone's gonna lose at Fall Guys. Yeah. Well, and the question is, like, even when you win at that game, it's like, how much chance goes in? There's a bunch of skill, but still, like, you could just get bumped off any easy way. It's like, it's just where you started. It's like, oh, man. Sort of like COVID-19. You do not know what's going to happen, and everyone's fighting for the resources. And this is why it's an interesting game, because it seems to actually be very contemporary. Okay, continuing. Major inequities would also arise from a self-made utilitarian approach by the clinicians left to their own individual intuitions. The risk of arbitrariness and disparities of judgment is only partially reduced by the recommendations that do not set specific thresholds and state that cutoffs must remain flexible. The aim is to provide a guidance, not a substitution of the individual clinical judgment. Last but not least, the individual physicians would be, as it happened in Italy, under a tremendous moral distress facing such a terrible task of improvising decisions about whom to treat. They would literally be out on an ethical limb. Yeah, we've had some very bad stories about doctors here in New York City, and one of them killed themselves after just not being able to save anybody. Too many people dying. Like, they're not used to having so many people die under their care, and so it was a pretty famous case. One of the top doctors hanged herself, I believe. So that was sad. In Italy, as elsewhere in the world, we were dramatically unprepared for such a startling emergency, and not just because we had not enough ICU beds, staffing, or funding. We were not prepared at all to face such dramatic choices. In retrospect, the CRD recommendations might have been written differently. It would have been better to have had a chance to involve members of the wider community in reflection on how to make decisions in the end of such a health emergency, as was done in Maryland in the USA in 2012 to 2015. What did we do in Maryland? In Maryland, multiple forums were held with the general public and with healthcare workers and disaster professionals using a deliberative democracy approach. Input from citizens was then fed into policy recommendations developed by an expert working group. This kind of approach would have given the recommendations greater legitimacy and might have provided additional support to clinicians. You know, that's interesting. I had no idea we had that. I mean, I'm sure that did not get used here because no one has heard, I've never heard of this. Which is the other problem, the other failure here is of government not actually, even when you have something, like someone actually did something right, it has to actually be implemented. So that's a different problem. How does we get the sort of the right policy in place and then have it implemented when it needs to be? Even when we know it, that doesn't mean it's getting enacted. Okay, let's get to the conclusion. It's not a long paper. We do not know what the future will be like after the pandemic, but it is clear that we should try to rethink the whole issue of allocation of scarce resources in emergency conditions, finding out commonly shared and accepted values to construct a contingency plan with sound and consistent ethical guidelines and proper structures, such as triage committees, to help apply guidelines, relieving the individual frontline clinicians of that burden. The approach is similar to other settings. This is not acknowledged by the general public, or better, by the critics of the triage recommendations. Now more than ever, we are aware that a universal, functional, and proactive public healthcare system has the best chance of appropriately facing an unforeseen outbreak of a viral disease. In full functionality is important at the early stage when no specific immunization or treatment interventions are available, since it guarantees proper infrastructures to mobilize a testing regime that provides the data that health policy leaders need to make decisions, and it guarantees a fair and consistent access to supportive care. It will become crucial later when drugs and vaccines will hopefully be available to define their price and deliver them widely, effectively, and fairly. We do not yet know if this hard time will turn into a global catastrophe, but should learn from the history of past epidemics that one of the highest risks is to give wrong priorities. Okay, box 2, key lessons from Italy. In emergencies, patient-centered duty to care needs to be balanced with public-focused duties to promote equality of persons and equity in distribution and risks and benefits. 2. In emergencies, when medical resources available are scarce, the first-come, first-served approach should be rejected. 3. As the development of rapid ethical guidance in emergency is difficult and politically fraught, an advanced planning for intensive care, including decision-making in the event of overwhelming demand, is needed. 4. A political and public engagement education in the ethics of resource allocation is needed to clarify priorities and values if they are to be reflected in allocation. Okay. So this is all of our failures, basically, right here, because this obviously was written before, for this to pass review, this is at least 3 months old and has not seen the catastrophe that the United States has currently got itself into, and it was even hopeful on the sort of Maryland thing going on. But so it's kind of interesting what sort of things need to be done for emergencies when it's a phenomenon of emergencies that the old sort of systems break down, and you have to sort of think on your feet, whoever you are, and do something, and all the people sort of are seen as sort of like the same, and that's why you kind of do the first come first serve thing. But of course that doesn't really treat people equally, that just treats people arbitrarily, and arbitrarily is not really equal, it's just sort of luck of the draw. The question is, how do you actually do this sort of thing? And rapid ethical guidance, like right here, this sort of philosophy does not move fast. And so it's like, this is you have to have look, you need preparation. There is no such thing as like rapid philosophy. Rapid philosophy, like I'm doing rapid philosophy now. This is terrible philosophy usually. It goes like barely above, like maybe barely above not terrible. But like mostly it's like if you're going fast through philosophy, you're going to miss stuff. And in this case, people are going to die. And that's bad. So this is the sort of thing. Advanced planning for intensive care, including decision making in the event of overwhelming demand is needed. This is like, we need a different way to do this. And I don't know if it's really ethical guidance or ethical planning in some sense. Who actually has to make the decisions, and what should their criteria be? Because at the moment it's just sort of not working. You can't. the shunting of the responsibility onto the frontline workers is a terrible sort of dodge of anyone in any position of responsibility. It's always, oh, the boss didn't know, and that's why the people at the bottom acted badly. No, that's a failure of management, not a failure of the people in the bottom. Usually, people at the bottom are always overworked and dealing with more problems than they need to be. So it's like, this is the question: is how do we actually get this sort of ethical intelligence built into the system from the get-go? And so this is the political and public engagement education and the ethics of resource allocation. So this is why I wanted to read that other paper, because how do we start to understand medical technology as a resource is sort of a very important topic because it's just pressing right now. All right, so what else to be said about this paper? And we need to understand medical technology in a different way. We have not been doing that because the current understanding of it is just, well, we have to help everyone egalitarian, but when the current medical technology fails, then we no longer have we can't use that sort of, the whole concepts from that sort of paradigm because it just doesn't work. It's already failed. And so then you're just flailing. So let's see, what was this thing over here that was interesting? Oh, yeah, because, and that's the other thing, a lot of times when you think you're doing stuff egalitarian, you're really just building in your conceived prejudices of who already counts as fair ahead of time. So, are we even fair at the moment, or are we really pre-selecting who we think deserves care right now? Yes, we like to think we're serving as many people as possible, but again, that always goes back to the political philosophy. Who gets to live and who gets to die is a political decision. And that's how a lot of the you say, oh, we're helping the people, but it's always some people. It's not all the people. I mean, it's like we could provide housing to the homeless. We just don't do it. Who deserves to have a house in this life? I mean, who gets to live? Who doesn't? Who gets a house to live in? We don't know. Like, it's a decision we've made in some sense. So, yeah, I completely agree with the statement that they said, look, the delivery of this stuff, of these, this criteria right here, was probably, this is not the best language for it. This makes it seem, as they said, age limits, like people jump all over it. So like, oh, you're killing my grandma. Well, yes, your grandma is going to die in like a pandemic, and that's kind of what they're saying here. But this is not really the way to go about it. I don't want your grandma to die. I don't want my grandma to die. No one's grandma should die just because they're old. That's an unfair way of doing things. Unfair and most likely very, very, very unethical. So the question is, like, how do you actually understand our level of resources versus the level of need based on people? If one person needs $3 million worth of resources to keep them alive versus that $3 million saving like tens of thousands of other people, how are we supposed to justify saying, well, I'm sorry, you're going to die because you just are too expensive to stay alive? Yeah, but then it goes to this pre-planning thing. So exactly, how do we pre-plan for pandemics? No, not pandemics. How do we plan for failure states? And that's a very hard thing. Like, what do we do when things start to break down? Do we go full Mad Max? Just like leave the decisions up to guys in fast cars? I don't know. For all I know, that is the best way. Although, yeah, I don't know if leaving anything up to Mel Gibson's really a good idea. Yeah, I'm pretty sure it's not. So, this is a question. What, was actually done here? Just because you have public engagement, that doesn't make it good. Maybe that makes it more palatable. Yeah. And the political will in this country is just lacking, so that's interesting. So again, the rapid ethical guidelines, I think that's an interesting concept that there even could be some such thing as rapid ethical guidelines. Basically, you have palatable political solutions is really what I think it comes down to, and wrapped up in some sort of ethical speech. So that's a question. Uh, the way things are looking now is that we really need to put a whole lot more effort into how the public understands prevention, and then once they understand the failure of prevention, how then can we get more reactionary when things really do start breaking down. But I think once we put more effort into the political will and the public understanding of things, then maybe we'll have a better chance at um, public distribution of resources, of scarce resources. Like they mentioned earlier, and I said, yeah, I completely agree, Aristotle. Like the safety net's just terrible here at the moment. It's getting worse. I mean, it used to be a little bit better, and now it's just failing. So, like when we have the like organ transplants, and it's a very scarce resource, and people don't sign up for organ transplants. It's hard to get people to do it here for whatever reason. I think the other countries are right where you're opted in by default as opposed to opted out. So that's the how do you like? But see, that's like a society level decision there. Opted in versus individually opting in. Aristotle says people couldn't afford time off, so they went to work sick. People couldn't afford to get treated, so they tried to shake it off. And so by the time they hit hospitals, they were acute, and that shit was bad. Not to mention the effects on stress, on healing, etc. No, that's exactly what's happening here. People have to work here because their health care is tied to work. You lose your job, you lose your health care, and like your family's health care possibly, and that's bad. And that's exactly why there's such a push to open schools up at the moment, even though it's obviously stupid. Like it's obviously stupid, and we're pushing to open schools up here because basically they want people to go back to work to make money, but the schools are basically daycare. And they can't, and they know they can't do daycare otherwise. Is the only way that people's kids can be looked after and not like get themselves hurt in most places. And so I mean that's one of the real difficulties in go away. Okay, sorry about that pop-up box. So this is one of the real difficulties that we have here is that the political will is not where it needs to be, and I just like this notion of rapid ethical guidance. Like really, how did we get to like rapid ethical guidance? That's like fascinating to me actually. We've got these I mean this is just me spouting off, but like, we've got these ethical systems that like are just gigantic things, and it's like they've taken like millennia to develop. It's like, and now we're gonna use them as like some sort of tool. We're gonna throw in like here, use this virtue ethics. That's how you just do that in this situation. We use this deontology over here. Here, let me give you like a modal operator. We'll throw this in. Best hope for America that the virus transforms into less lethal strand. Yes, praying for a miracle is probably our best hope. Otherwise, we're just gonna keep being bad for at least a few months until we get some sort of herd immunity in most places. But that's just like a terrible solution. That's the non-solution. That's letting it run its course out and letting our biology do its work. But I mean, that's just sacrificing people. I mean, who wants to sacrifice people? That's terrible. Okay, so I don't think I have anything else smart to say. I don't know if anything I did say was that smart, but it's just this sort of, how do we have the ethical resource for pandemics? Yeah, well, Aristotle says, I'm not really opposed to rapid ethics, but it's a no-win situation. By the time you're in a pandemic, you're not facing normal problems that go rapidly. Thank you. Well, professor of Twitch. I mean, I'm on Twitch professing stuff, I guess. Thank you. Yeah. You've got a good point there. Yeah, I mean, rapid ethics is basically what you actually have to do in real life. But the idea that we're gonna have something we can deploy in a pandemic, I just think is funny. But I mean, you're right. It's a no-win situation, so that's exactly what we're going to be doing. Yeah. So, I mean, but it just seems like a punt to me. Like that, you're just punting it onto the people. It's like, here, take this like ethical toy and try to apply it to this terrible situation. It's like you gotta be kidding me. You're giving like some poor doctor and nurse where they've got like an impossible situation. Like here, it's like one of those TV shows, medical doctors where they're trying to save everybody and it's impossible. So yeah, I don't know. I should really probably think about this a bit more just because it is so pressing nowadays. It seems to be the thing. All right, everybody out there, have a great night, day, whatever time it might be, time appropriate greetings to you, and stay safe, and I will be back soon. And thanks for stopping by, Aristotle. I appreciate it. Bye-bye, folks.